How can we make the world better? By making ourselves better. The Dr. Joe Show explores how you can make positive personal change by using his groundbreaking and highly effective I Am approach to understand who we are and why we do what we do. Your small changes can have big effects.
Join us now for the Dr. Joe Show with Mark Stiles of Stiles Law, Thomas McCoy, and your host, Dr. Joe Schrand.
Ladies and gentlemen, welcome to the Dr. Joe Show. Could you tell?
I could.
I almost fought through it. I didn't do my voice exercises before this time.
You know, I tell you, it shows sometimes, but it still has a unique.
Oh my gosh, that was a frog. They would call that a frog, right?
Yeah, that was a frog.
I had a frog in my throat, I realized it right when I started the introduction. That was
it, and I could see that in your eyes.
You're a real broadcaster now, Mr. Stiles.
Should I have pulled back and cleared my throat and started over?
No, I think it was great. I think
because it was live. You
live.
Go.
I feel very happy about it. I do. I told you about that.
Oh, buddy.
Sorry, I'm gonna stop.
No, don't.
No, I won't. But that you powered through that.
I think I actually cleared my throat while I was doing it.
I think we heard that. I'm surprised that there isn't like Louie on the microphone.
I was going to say
now,
that. Well, thankfully there's a screen here now. Yeah.
Sorry if they run it out there called Louie. So how's the week been?
Great, fabulous, fantastic.
With that in mind, talking about gratitude, I have an amazing guest here tonight, and I'm very grateful that you are here as well, Don Marks. Dr. Don Marks. I arguably, maybe not that arguably, I think one of the best neurologists on the South Shore of Massachusetts.
Wow.
So, yeah.
That's a big statement.
No, but it's true. So, welcome, Dr. Marks.
It's nice to be here, Dr. Joe.
Ah,
And Mark, I have to say that the PanMass Challenge is about writing for the disease cancer. And Alzheimer's disease, which I'm going to be speaking about, is the cancer of the 21st century. And because it's older people, we don't ride, we just have Alzheimer's walks.
Yeah.
But it has more or less the same goal. And
the cancer of the 21st century.
Yeah, I mean that
really
insofar as cancer was one of those things which people didn't want to talk about because there wasn't much you could do about it 20, 30, 40 years ago. And so if you can't do something about something that's deadly, maybe we don't want to talk about it. Once it became treatable, it's a very different story. I remember when I was young, I'm 69 now, I remember my father died of cancer at age 42 in 1968. There wasn't much that could be done. A little bit of cobalt treatment, that was it. So it was at the time, we don't talk about it. Now we do talk about it. I'm hoping that the same thing will happen with Alzheimer's disease. I think we're already well on our way. And that's part of what I wanted to get on the radio about. For the last 25 years or so, I've been telling my colleagues as well as patients that we really need to move forward about the diagnosis of this disease. And one of the pushbacks was, well, okay, but what can we do about it? We had some medications, still do, that help treat the symptoms to some degree. Sort of like if you had polio and your knee buckled and we gave you a knee brace, you could walk a little better. It wouldn't do much for the polio. And at this point, we've been waiting and waiting and waiting and waiting and waiting for a drug that might have some true disease modification effects, meaning it changes the course of the disease, much as chemotherapy and other treatments might alter the course of cancer, not just treat the symptoms. So, about June 7th, there was an announcement that the first drug was approved by the FDA for altering the course of Alzheimer's disease. This is after a very, very stormy course. And actually, the stormy course up to that point looks tame compared to the storm that's ensued. The problem is that the drug was approved in a very odd way. It's called aducanumab. It's manufactured by Biogen out of Cambridge, and it was approved for the management of Alzheimer's disease, all Alzheimer's disease. The clinical trial, the studies that were the basis for it being approved, were not done in all people with Alzheimer's, but just people with very mild forms of the disease. So a couple of weeks later, they decided, oops, maybe we better walk it back. And they changed the indication to just those people with early disease. Now, in addition, going back to the cancer analogy, which I'm sort of glad that it had the segue it did, because It's very apropos. The FDA decided 25 years ago or so that when you have a tumor, that most tumors express proteins on their surface which get discharged into the blood, and that you could measure the amount of tumor indirectly by measuring the amount of these proteins in your blood, called a biomarker, as opposed to measuring the tumor itself. The idea being, if you wait a few years for the clinical trial to be done, a lot of people will have died in the interim.
Right.
So the idea is, how do you get it out faster but intelligently and meaningfully? So what they decided was to use biomarker changes as the basis for approval of cancer drugs. Fast forward 25 years. Now they decide with Alzheimer's they're going to do the same thing. There's a protein called beta amyloid that builds up in abnormal quantities in the brains of people who are destined to have or already have Alzheimer's disease. And the idea was, if you could give an antibody, these engineered monoclonal antibodies, that would pull out the amyloid, that hopefully that would alter the clinical state of the patient. In other words, their mind would be better, or at least get worse less quickly.
Yeah.
So what happened is that these drugs, this class of drugs, does get rid of the amyloid, the beta amyloid, very nicely. But the clinical trials upon which the approval was based, unfortunately did not demonstrate as robust a clinical response, meaning that it gets rid of the biomarker, if you will, but did it have an actual effect for patients' well-being? And the answer to that is murkier. And so there's been a firestorm of those of us involved. I was involved in the drug trial for the drug, still are in a follow-up trial. But the question is, was it good enough to have approved? In addition, it's $56,000 a year.
Wow.
The Alzheimer's Association had gun for it being approved. They were not happy about the price. And so there's a lot of discussion. And for me, as someone who's involved in clinical research since the 1990s, one of the more chilling aspects is, if you have a bunt single, do you end it there? And so if people say, well, we have nothing, it's better than nothing. You know, I had a second cousin who died of leukemia when she was 10. I was 12 at the time. And a year later, they came up with the first drug that was used for leukemia, and it saved about 20% of the kids who had leukemia. But if it had stopped there, then the nearly 100%, there's a few exceptions now, that we never would have gotten.
Right. Let's go back over some of this, because there was a lot of information, some technical terms that people might not completely understand. But let's go back to the basics. What is Alzheimer's?
Well, once you know, tell me, and we'll go to Stockholm.
There we go.
The current hypothesis, and to emphasize, it's a hypothesis, meaning that it is a reasonable description, but without complete proof, is that there is an abnormal amount of this protein in the brain called beta amyloid that is associated with people who either have or are developing Alzheimer's. The ways of measuring it are somewhat difficult.
I want people just to understand what protein is, because we're not talking about like steaks in your brain.
It's it's hard when this is a radio show and I'm trying to get some basic information out there.
Right.
It's so hard because these are all long discussions.
Right,
I mean,
right.
if someone needs to understand what a protein is, in and of itself, that's a significant discussion.
That's true. But in essence, the proteins are sort of like the little machines in our body that get things done and tell parts of our cell to do other things. And then there's this protein called amyloid. And what happens to that one that may result in people having memory difficulty?
So we think it's the trigger, sort of. If you think of it as a gun, the trigger is the amyloid, and the bullets are another protein called tau protein.
Tau, T-A-U.
T-A-U, the Greek letter tau, that's where it comes from. Amyloid is a Greek term for starchy, and it has to do with 150 years ago when they used to stain cells. It had starch-like characteristics.
Yeah. Cool.
But anyway, I mean, each of these terms has its own sort of interesting medical history.
Right.
But the tau protein, if you think of the old cartoon, The Jetsons,
Yep.
and for those of us old enough, and for those of us otherwise, there's Nickelodeon or whatever is the current way. Anyway, there was these tubes where they would go racing through space, and they were held up by little girders. Well, if you think of the little girders as tau protein.
Okay.
So you have these microtubules akin to the Jetsons tubes.
Right. Micro meaning little tubes.
Little tubes.
Okay.
Can't see them. They're way below our ability to see them.
Huh.
And the products that the cells need to talk to each other, called neurotransmitters, are transported up and down. The food from one end of the cell to the other is moved down. The garbage is moved in and out.
So
So
cool.
once the microtubules fail, as the tau protein pulls away, because they get polluted with little side chains on them that cause them to fall off the microtubules. Then they clump together. It's called an aggregation. And then they poison the next cell in the connection of the network of the nerve cells. And so the idea is that if you can prevent the amyloid from triggering, the excessive amyloid from triggering the next step of tau falling apart, which actually destroys the cells and is the basis for the cell death. It's more complicated than that, but for purposes right now, that's sufficient. That if you could prevent that further step, then you can prevent the disease from progressing.
So how do you do that? How do you do that?
That's
Can
the
we have the answer to
Nobel
that?
Prize question right there, Mark Stiles.
Exactly. So the focus has been to get rid of the amyloid for a long time. In other words, put trigger locks, if you will.
Yeah.
The problem is if the 6-shooter's been fired 4 times, putting a trigger lock may have a limited benefit in terms of the remaining 2 bullets.
Right.
So we've sort of proven that getting rid of the amyloid too late in the disease, which is not necessarily advanced disease in terms of how people are operating, but biologically what their brains look like, it just doesn't work. So
once it's unhinged, it's
once
too
the
late.
trigger is fired, then it's too late. So the idea is to try to block the triggers earlier and earlier. So this drug that was just approved, think of it as a trigger lock for people who have mild symptoms of dementia and mild cognitive impairment, which I'm going to come back to in just a moment.
Okay.
So the next step is to look at people who have a high amount of amyloid, which they may have for 10 to 20 years before they have any symptoms. And to find those people, particularly where there's families with a lot of Alzheimer's, because they cluster for reasons that are complex. And the idea is to try to give those anti-amyloid vaccines to get rid of the amyloid in people who are pre-symptomatic, no symptoms. So that's the next step of what we're looking at. In addition, people are saying we've played out the amyloid hypothesis well enough, and what we need to do is start looking at things that block tau. So even if the triggers are pulled, can we block the bullets from doing further damage? So that's the basis
you use
of
the
things.
phrase anti-vaccination.
Yeah.
Why do you call it that?
Yeah, it's somewhat of a misnomer. A vaccine is really a way, as we usually mean vaccine, it's a way of training our immune system to recognize foreign proteins such as virus capsules with COVID, to be hyper responsive when they see those proteins and destroy them. In the case of Alzheimer's vaccines, it's a little different. These are passive monoclonal antibodies. What that means is in a test tube, they create antibodies against the amyloid protein. And then they give you an infusion, an IV infusion, so that you get a large dose of these antibodies. And they grab onto the amyloid, trigger your own immune system to start chewing it up, because when an antibody grabs onto something, that's a signal for your immune system to come in, the goon squad to come in and wipe it out.
Right, do all sorts of things and basically eat it up with these giant macrophages, large phage eaters. That's right.
Right.
So we are now looking at modulating an immune response to prevent or at least treat Alzheimer's?
Yes.
Proactively.
Proactively. It's you're using the immune system in a controlled manner. I don't think the emphasis is so much on that. That's pretty straightforward. It has to do with picking the right antibodies.
Yeah.
And at the right time. But I want to go back to something. Look, the problem with Alzheimer's right now, among many, but is acceptance that it exists among the general population. Acceptance by primary care doctors to even look for it. There's a lot of reasons why that's not happening, which I'll go into in a moment, but Alzheimer's disease and dementia are not the same thing. Very important for folks to understand this. Dementia is simply a functional description. It means that you have a brain which is not working well enough that you cannot function independently in ordinary life, in your usual life pursuits. You can get dementia from multiple head injuries, multiple strokes, Parkinson's disease, multiple sclerosis. There's a huge list of causes of dementia. It just means you can't function autonomously anymore.
So dementia is the description of a symptom like a cough,
Right.
but it doesn't tell you why you're coughing
Correct.
or why you have dementia. This is just the symptom.
It's a description.
Right,
It's a description of function.
Right.
Now, Alzheimer's is by far and away the most common cause of dementia in the United States for people who are elderly, but is by no means the only one. Now, before you get dementia, you also can have what's called mild cognitive impairment, MCI, not to be confused with the prison system. And MCI means that you are not the way you were, but you are not bad enough to where you can't function autonomously anymore. So that varies on what you did. If a college professor suddenly can't figure out how to give lectures, but they're still able to manage their affairs at home, technically they have mild cognitive impairment because they can't do their usual function. So it's a bit murky, but it has to do with your baseline level of function, whether or not you've lost that or not.
So I've heard that college professors who have that, they've lost their faculties.
They have. They have.
No, that's the dean. I'm sorry.
Yeah.
Can I ask you a question?
Stop. Yeah.
Sure.
I'm a big fan of being proactive. Proactive medicine,
That's right,
proactive law,
absolutely.
everything. Do it in advance and you'll be happy. You said something about 20, 30 years. Is there a blood test or something that people can take to understand where they are with these beta amyloids?
Yes, that's a very hot topic right now. There are blood tests that are being developed. There's one that's FDA approved. It's about $1,100, not cheap. And
But worth it if you find out that you have it and you can.
and if you have a
stave it off.
treatment.
Right.
See, until June 7th, it was like, well, that's nice, but what are we going to do about it?
Right.
Now, you have to validate. What that means is that you have a gold standard of what everybody agrees is a positive test. And you have to compare new tests to that to see if it's equally valid.
Well, that's science, right? You're always
Exactly.
making it better.
So we're working on the validation. When I say we, I mean thousands of people
Right.
are working on the validation of new blood markers. And it may be that the blood markers are a screen that your primary care physician can do. And then if it's positive, then it gets referred further on to specialists to try to deal with this. Now, that's part of the problem, is that there's just not enough specialists to deal with this.
Yeah.
The population of Alzheimer's patients in the U.S. is estimated, it's approaching 6 million, it's around 5 million now. There's only hundreds to a couple thousand neurologists who are trained in neurobehavioral technique to serve all of that. You do the math. And so how do we make this screening occur, and then how do we take care of all these folks? The determination and the nuance of treating folks with these newer classes of agents that can alter the disease course are complicated.
But that there actually may be now a medicine that could work?
Yes, there is a medicine that works at worst marginally, at best a little bit more than marginally. As I said, it's a bunt single.
Yeah.
And the point is you can't stop with a bunt single.
Right.
So where do we go from there? That means getting people engaged in clinical trials, volunteering to be in trials. If you're the child of someone who has had Alzheimer's from a parent or a sibling, and you're over the age of 55, there are national clinical trials. We're involved in one of them that are looking at people who have evidence of the abnormal amyloid protein we talked about, but have no symptoms yet. And the idea is to see if we can prevent it from ever progressing.
Yeah.
These medications, by the way, do not change what your behavior is now. Whatever damage is done is done. The idea is to try to slow down the progression, not necessarily even stop it, but slow it down. I don't know, maybe you live another 20 years and you die of terminal baggy skin. But, you know, the point is that is to try to extend it out. I mean, that's what cancer goes. It's I mean, you may not quote unquote cure it, but if it's kept at bay till you die of something else, okay.
Right.
It's true. With so many chronic illness, like
Yeah.
diabetes as well. You know, you're just trying to keep things under control.
Right.
We had a call in. Actually, it was a text from Paul Zani, who actually was a director of some of the psychiatric hospitals I worked in. He said, "How are people meant to afford this? You know, if they're on Medicaid, how do you afford over $50,000 out of? That's going to be out of pocket, right?"
No, Medicare is working on it. Look, in the United States, under George Bush II, it was decided that Medicare could not negotiate for price. In every other country of the world, there's negotiation for price. The U.S., through the NIH, which funds most research through universities, and through our pricing of drugs, supports drug research for the entire planet. And this is a political issue, and it's difficult. In Massachusetts, you know, the major teaching hospitals make money off of doing research. And so if you cut down the research dollars because you try to drive down the price of the drug, it cuts both ways. And so it's a thorny problem, but obviously a lot of us are hoping that this may be the tipping point. It's finally the drug that is expensive enough and is used by enough people that there's no way that they can't finally come back to that fundamental problem. So Medicare right now, there's 10 regions of Medicare across the country called MACs. There's an intermediary agency that negotiates for the region. And each of the MACs is separately figuring out how they're going to handle it. Medicare has a select committee trying to figure out how to deal with this. It gets more complicated because in order to diagnose the disease, we don't have a blood test just yet. So you have to either do a spinal tap, which is not as nasty as it sounds, to look at for the amyloid, or a very expensive nuclear medicine test called a PET scan.
Okay.
And the PET scans run $4,000 to $5,000 out of pocket. Medicare did a study a few years ago, we were involved in that as well, looking at whether or not it was beneficial to do an amyloid PET scan to help with diagnosis. It clearly was. It's not paid for. Medicare, I am told, from what I've read in the last week, is reconsidering paying for amyloid PET scans. That's a huge amount of money for Medicare. In addition, these drugs can cause some temporary swelling in the brain, usually no symptoms, but you have to monitor it and adjust the dose based on that. That requires multiple MRI scans. Who's going to pay for that? It's an extremely expensive proposition. The drug trials cost $2 to $3 billion each because they're very complicated looking at all these factors. So it's a great question, and there's not an immediate answer to it. All of us are feeling our way through this, trying to figure out who should be on the drug, who should not, who we would encourage to be in a drug trial. And it's what we call shared decision making. It's not my decision to make. It's a discussion or discussions that we have with patients and families trying to decide the best course of action.
How close do you think they are to a blood test that we can go into our primary care and draw some blood and, okay, you got some amyloids, let's go get the Biogen drug and stop this from happening?
Well, see, it's unfortunately a little bit more complicated than that. We have to first validate, as I mentioned earlier, that the blood test is analogous to what you see in the brain, and they're working on that. The answer to your question is perhaps 2 to 3 years.
Good. Unless the science stops.
Unless,
right?
well, the science isn't going to stop on that. But the fact then remains, the primary care doctor should not be in the position of ordering this.
So who does?
That's the problem, is that it should be people who have some experience doing this. And I'm saying that not out of a means of maintaining business, but just in terms of taking care of people. These are primary care doctors are overwhelmed. The best I would hope from a primary care doctor, putting aside what you just said about a blood test, as part of Medicare's annual wellness screening is you have to do a mental status exam.
Right.
A lot of them don't. Some of them do. And the idea is if you see an inkling of cognitive impairment, they usually send them to us to take further.
Got it.
Right.
So you make the referral and then they take a deeper test.
But we're dealing with this right now at a national level. This week in Denver is the Alzheimer's Association International Conference. It started as a little tiny conference about 20 years ago. It's huge now, and because of COVID, it's a virtual conference, and so instead of all people from around the world who couldn't afford to come to these U.S. conferences, now there's tens of thousands of people listening to it. It's an extraordinary conference. So in real time this week, there was heavy discussions about some of the questions that you're asking.
Awesome.
And so it's very much in real time, which is part of the reason I asked Joe if I could be on the show, because this is not just speculation anymore. This is really happening. And so because of my involvement in the research, I see myself as being a bit of the spearhead in terms of our region of getting the knowledge out.
That's very exciting.
Yeah.
June 7th.
Yeah.
That was a big day.
Big day.
And they had delayed it by 90 days and 180 days because the FDA didn't know what to do about it. The independent advisory panel of neurologists said do not approve it.
Really?
The internal committee of the FDA said they would.
Why? Why was there an
For the
internal
reason that I
debate?
told you, that there's the anti-amyloid. That's a good question.
But I already answered it.
I already answered. Damn it! No. Actually, no. That is the core of it. And what it was is that the concept that getting rid of the amyloid, the biomarker, didn't necessarily, based on the evidence that had been produced, correlate well enough to say it has clinical benefit. Okay? In other words, people were saying, yeah, it's great, it's a biomarker, we need to do a little bit more, we don't have enough data.
So what
We
makes
need more tests.
what makes this medicine different? Because there have been medicines that have been out there for Alzheimer's, or at least to slow down the progression. What's different about this one?
The medicines that have been out there have not been to slow down progression.
Okay.
What they do is they treat symptoms. And to go back to what I said earlier, if you had polio in your leg and you when you went to stand up, we're on video?
Yeah.
All right. Okay. So
WATD listeners, I will make the announcement.
You'll do it. You'll do
Don
the
Marks has
play-by-play.
been standing up.
So say you have polio in this leg and you go to walk and your knee buckles and you can't walk.
Yes.
And I give you a knee brace and now you can walk like this. Did I fix the polio?
Now you just...
I just gave you a functional benefit from the
Right.
brace. Now, let's say the polio goes to this muscle that moves your ankle. So now your knee is a little stabilized, but now your ankle gives out. So you're still getting worse, but you're better than you would be if you didn't have the knee brace, even as it progresses. Okay? That's called symptomatic benefit. That's not disease modification. So we've had oral drugs since the late 1990s that have been good for symptomatic relief.
And what are the symptoms that they're relieving?
They help with attention, focus, memory. They're said to be memory drugs. What they really do is they enhance attention and concentration, which indirectly leads to better memory. If you're more in tune with your environment, more aware of it, more engaged, then you're more likely to retain information.
Like an ADD type of drug.
So yeah, in a way, unfortunately it's somewhat different than that.
Okay.
You still have a fundamental problem with the formation of memory and the ability to go back to memory.
Yeah.
But in a sense, you're right that if your focus is better, then you have a better chance of getting it in. But unlike an ADD patient where their memory's working pretty well, they just can't sit still long enough to get it in.
Yeah.
This is both. You have a problem with sitting still to get it in and attending to it, but you also have a problem with it being deposited in your memory.
How painful is it for the patient to try to go back and capture that memory?
For some people, it's extremely painful, and they have what we call a catastrophic reaction. They get very emotionally distraught. For other people, as Ronald Reagan, who had Alzheimer's, said, there I go again. So there are people who have a sense of humor and self-deprecation, but unfortunately, the disease affects different parts of the brain differentially in different people. So you can have what's called executive dysfunction. The frontal lobe systems don't work as well in particular, although it's more complicated than that. But the fact is, these folks don't know that they have a problem. It's called cognitive anosognosia, not knowing that you don't know. That's hell on wheels for families. Very difficult. Difficult to get those people to medical treatment, difficult for families to cope with it. And so there's a lot of subsets. There are people who have very good executive function. They are socially with it. They appear normal on the surface, but you ask them to draw the face of a clock and they can barely draw a circle. So it affects different parts of the brain in different people. So in a sense, it's probably not Alzheimer's disease, but Alzheimer's diseases, and we tend to lump it together. I suspect over the next couple of decades we won't see it quite the same way.
So we may be able to tease them apart. This one's this one's that. And
But by then it'll be gone, because we'll have had it all figured out by then.
Well, it's going to take a while. There's also going to be a bolus of people who are far enough along. So even if we found a quote-unquote cure that stopped it dead today, you're still going to have a lot of people who will continue to progress and for the next couple of decades.
So, Dr. Marks, how do people get involved in these trials?
First of all, you need to acknowledge there's a problem. And normal aging is a term which probably is not all that helpful. I take care of 95-year-olds who are probably sharper than I am. That might be more common on me than them. But the point being that it's not inevitable that you have forgetfulness in the way we normally think of it. It's just that it's a very common disease. At the age of 85, 1/3 of all people in the United States have Alzheimer's disease clinically. So it's extremely common. At the age of 90, it's 1 in 2.
Wow.
So when a 90-year-old says, well, a lot of my friends are forgetful, I go, yep. But anyway, which means that there's a 1 in 4 chance that a couple will both have it.
Wow.
Which is hard on the kids.
Wow.
So the reason to be in a clinical trial, I found that the greatest generation, who were the people mostly in the trials early on, although that's moved on, I'm now seeing boomers, people younger than I do who have it, which is sobering, is that they had a sense of social purpose. They had a sense of the greater good. And to be in a trial, I always tell people, if you're going to walk in and say, oh, you're going to cure my Alzheimer's, doc, I go, not really. First of all, we're going to try to slow it down, not stop it. Number 2, if that's your goal, that's probably not a good idea. That what you really need to do is to do it for the greater good. Now, the greater good may be that 10 other members of your extended family going back 2 generations on both sides have had it, in which case everybody down the road has a very high risk, not a certainty, but a high risk of getting it. You may have friends who had it. You may have had a very good friend who had it. So you're taking one for the giver, that you're taking one for the team.
Yeah.
And so I always tell people you need to have that civic sense. What I will tell you is people that engaged in clinical trials are extremely monitored closely. So it's some of the best medical care you'll ever get, because every time you burp, we need to know whether it's due to the drug or just you were going to burp anyway.
Right.
So as a matter of fact, that's how the side effects get figured out when you look at the little 2-point font sheet that comes with a new medication. It came from the drug trials. So Anyway, so I would want people to have a proper sense of why to get involved. Proper meaning that they do it for the greater good as well as themselves. We certainly hope it helps them, obviously, but that cannot be the only goal. These are mostly double-blind, placebo-controlled trials, meaning that me giving the drug and the person getting it doesn't know whether they're getting active drug or saltwater solution. These are IV drugs. And it's done on purpose, so there's no cheerleader effect, the placebo effect. And for most trials, there's a period of time when you are on active drug or placebo, and after a year and a half, you get switched to active drug if you were on placebo, and you continue on active drug if you were on active drug. In other words, you don't go without something forever. The exception to that is in trials that are for people who do not have symptoms yet. And those trials are not crossover designed. In other words, you're either on placebo or active drug for the entire time. And the reason for that is that you don't have a disease yet that's manifest by clinical symptoms. And if you do suddenly show some symptoms of worsening dementia, at that point you can then get the symptomatic medications. I don't want to make it too complicated, but people say, how can they get in the trial? The name of the trial that's for family members who don't have any symptoms yet is called the AHEAD trial. We started doing clinical trials in Plymouth back many years ago because it was very difficult for people to commute through Boston traffic to get to the teaching hospitals. To this day, I have colleagues at Mass General who will send me patients because they live down our way because it's just too hard to go in and out. So I'm in practice for 36 years in Plymouth. You can look me up and call our office if you're interested in this. There are websites for the AHEAD trial if you want to look at it. It's AHEAD. And
is this a national?
It's a national. It's a national. Yes, this is.
We have national listeners really all over.
Yes, there are about 50 trial centers. Most of them are academic centers. There's a few of us that are not, and we're very pleased to be able to offer this. And so anyway, the point is that it's readily accessible if you just with minimal effort look online at the AHEAD trial. There are also many, many other drug trials for people who already have symptoms, as I was alluding to earlier. We have this newest drug that was approved that I said is a bunt single. Yeah. But if you want to see if you can get a double or a triple or even a home run, there are other drugs that are enrolling, and we strongly urge people to consider that. There are people who will say, no, I'll take the bunt single. Okay. But it's expensive, as we've talked about a little bit already. It's in a state of flux as to how that cost will come down and who will pay for it. I don't think anybody's going to be charged $56,000 out of pocket to do it. So we'll see where that goes.
AHEAD, I like that. That's easy to remember. It makes sense.
Right, exactly.
It's for AHEAD.
Yep.
Get ahead.
Yep.
I love it. And all of the trials can be found through you, Dr. Marks, in Plymouth?
Yes. And also if you go to clinicaltrials.gov, it's the national website for all clinical trials. It's pretty easy to use. You just put in Alzheimer's and it'll tell you tons of places that are doing trials of different types of trials.
Okay. So this may have answered the first question from the IM. So the IM, has two rules because the four domains interconnect. Your home, your social, the I see, how I see myself, how I think other people see me, and the biological domain, which we're talking a lot about tonight. Small changes can have big effects. You don't need to change everything. Dr. Marks, what small change can you recommend to our listeners so that they can manage Alzheimer's if it's in their family?
Well, I think the first thing is to realize that denial is not just a river in Egypt.
That's right.
And that is the major impediment. And it's not just the families and the people who are exhibiting symptoms. It's the medical profession as well. The primary care doctors are busy. Some of them don't have the knowledge or interest to pursue this. You need to be your own advocate. But I would say that if you're in your 60s, even late 50s, and having significant memory problems for reasons that you can't explain. Look, if you're not sleeping but 2 hours a night because you've got untreated sleep apnea from weighing 500 pounds over what you should, that's going to cause you to have memory impairment. But assuming that there's no clear reason for it, then you need to tell your doctor, look, I think that I'm having memory problems. Can you do some screening tests? And if the screening tests are positive, then ask that you be sent to the next step.
Are organizations like AARP or other things, would you recommend them? Are they helpful? Should people join up?
Yes, the AARP is useful, but the biggest organization is the Alzheimer's Association. It has one of the deepest, widest websites of any disease state I've ever seen. For that matter, any website. If you want to get into the weeds of arcane new research development, stuff that I work with, and my peers who are involved in research work with, it's there. If you want just simpler things about how do I do this, how do I do that, how do I handle this financial situation, how do I handle bathing with a more advanced patient, it's all in there.
Wow.
So what's that website again?
It's
The
Alzheimer's.org, I believe.
Alzheimer's.org.
Yeah.
Really important
Yeah.
resource for people.
Yeah.
The second truth of the I am, because everybody's interested in what other people think or feel about them, and you're part of someone's home or social domain, it has an effect on the biological domain, the way you see them, because you know it feels differently if you're treated with respect or disrespect. You control no one, but you influence everyone. You get to choose the kind of influence you want to be. Dr. Marks, what kind of influence are you hoping to be?
Doctor comes from the same root word as educator. And what I would hope to accomplish is to just increase people's awareness so they can then be enfranchised to take action on their own. That there's a certain amount of basic knowledge about the existence of this disease and where it's going in terms of our treatment that people just need to know exists. And if I can do anything to make that happen, if by telling whoever is listening to this what's going on and have them each tell somebody else, that's probably the best we can do. I do view a lot of this as retail, if you will. It's one-on-one. I spend an hour and a half with a new Alzheimer's patient and their family. I do it in part because some of it is subsidized by the clinical research. It allows me to do it. It leads to a place where people feel that they're compassionately and completely cared for, that they're listened to, that we have time to address a multitude of questions, the sort of questions you guys were asking tonight. And it allows them to move forward and not to just be in panic. And I think that, that's what we try to accomplish.
So there's hope?
Oh, definitely.
Would you have said that 10 years ago?
Oh, even 10 years ago I said there was hope, but the problem was the hope was just beyond our grasp. What the hope is now is that we're now going to do combination therapy, where we'll be using this type of drug and maybe an anti-tau drug, as I talked about earlier. And it may be that the way forward is that by perhaps prematurely allowing the anti-amyloid drugs to be approved, that then will allow, as an existing approved drug, for another experimental drug to be added on, because you won't be on 2 experimental drugs at the same time. So this is what we all have been hoping for the last 10 years, and it's finally happening.
It's happening.
So exciting.
So we started off talking about cancer and the difficulty. All those years ago, people didn't talk about it, but now it looks like something's on the horizon. Thanks for leading the way with that, helping people. Really appreciate it.
Thanks for the opportunity.
All right, folks. We'll be back next week with the Dr. Joe Show. Thanks, everybody.
Go, 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 go.